topic in focus today is on hemoglobinopathies with a focus on sickle cell disease specifically. This session's being recorded and just to let you know that you will also get a chance to ask questions at the end. If you look in this room, there are some microphones down the middle and down the gaps on either side, so please do feel free once the discussion kicks off at the end to come and ask questions to our panel. So the format of today is that we have two chairpersons to my right, who I'll introduce very shortly, and three speakers to my left. You're going to hear three presentations, and then we're going to have a discussion about them at the end. Just to reiterate that Topics in Focus, the whole idea behind that is that it's a program of educational activities that is meant to foster networks, improve research, and as well as increase awareness around specific disease areas. And today the focus is on sickle cell disease. So, without further ado, I'm going to introduce the chairs of the sessions who are going to introduce the speakers to you. On my right, I have Professor Nika Capellini and Professor Ali Taher. Nika, if I could start with you, why do you think sickle cell disease is so important?
Definitely, I believe that there is an urgent need to increase awareness among hematologists and physicians in general in Europe, in Northern Europe, where sickle cell disease wasn't so common and in other parts of the world. And due to recent migration, we have to be prepared to face these kind of disorders, these kind of patients who require attention.
Okay, thank you. And Ali Taher?
It's an orphan, neglected disease with very few treatment modalities.
Okay, thank you very much for that. So on that note, I think I'm going to hand back to Nika to present our first speaker for this afternoon.
Yes, it's my pleasure to introduce Professor Stefan Eber. Stefan actually has been trained, he's a pediatric hematologist, and he was trained, can I say, years ago, but that is a good sign, at Children's Hospital at the Harvard Medical School. The main important aspect I want to underline, Stefan actually dedicated his life to benign hematology, and actually he was working on rare anemias, coagulopathies, and especially he has a great experience in lab diagnosis and techniques. So he's going to present us the screening program, early detection and diagnosis. Please, Stefan. He's now based in Munich.
Thank you very much for this nice introduction. Now we need this one. And okay, so I have two persons I really owe to mention. This is Roswitha Dickerhoff, a very renowned hematologist in Germany for, I would say, the mother of sickle cell disease in Germany, who moves to Munich, and I'm glad that she will join us in our office in Munich, and Stefan Lobitz, who made a session on the neonatal screening program in Berlin some time ago and gave me the slides for this part. And he cannot come because he has a private date he marriages, which is, of course, an excuse for not showing up here. So I have no affiliations with industry, and now I would like to give you the most important things. Why and whom to screen for sickle cell disease. I try to view the German state, and I try to give the presence of screening measurements in Europe. Why? To avoid morbidity and mortality from infection and acute anemia, to initiate preventive measures in a timely manner. That means penicillin prophylaxis, vaccination, and education about fever, symptoms. And you know, we have to enlargement of spleen, to teach the parents to observe that. And whom? Whom is very important. Newborns defined as being at risk for sickle cell disease based on ethnic origin, and I will come to this point in which countries this would be of benefit. By comparison, for countries such as England and France, it might be more convenient to do a universal screening versus a selective screening. And I think this depends on the frequency of the disease in each country. And I think we should consider sickle cell disease is not as an imminent dangerous disease as a metabolic disease. It's not hypothyroidism, for which children die at the first days of life. It takes some time. And I think this is an important message. No newborn screening without a disease management program should be offered. So just a short overview, and I hope I kept every data right. I think the most broadest screening is done in United Kingdom with every pregnant woman, prenatal, and every newborn studied. And I think this screening also is very efficient because 80% of the newborn children are seen, or newborn children detected by this screening are seen with a specialist at 3 months, and I think nearly 100% are seen with 6 months. So still there are some lost of siblings due to pneumococcal infection, as I was informed, this was 3 siblings dying, and only 2 resident cases were not identified by the screening. So I think this shows that this combination of screening is very effective in United Kingdom. France so far does a selective screening, but is possibly switching to a universal screening. Spain is doing universal screening. Belgium does a screening in major towns. I think this might be the same in Italy, where patients are concentrating in some towns and other areas are not with sickle cell disease. And Netherlands are doing universal screening again. So it depends on the frequency and the experience of the respective country. The basic principle is, and it's very easy, the presence of hemoglobin S or any other hemoglobin variant and the non-presence of hemoglobin A. There is no other disease. You cannot mix a carrier with a sickle cell disease if you respect these 2 easy to detect principles. The methods are widespread, and we in our laboratory in Würzburg use HPLC, but capillary electrophoresis, isoelectric focusing, tandem mass spectroscopy is done in United Kingdom and Wales, and cell electrophoresis are also very appropriate to early detect for newborn screening. What about carriers and thalassemia? Carriers should be reported to increase the awareness in society, to identify families at risk and make a family counseling. And please remember, or let's say in Germany, it's not allowed to inform carriers because there's a right not to know anything if I'm not affected. So we must respect each country has individual rights about that. Thalassemia carriers should be, or patients with suspected thalassemia should be reported, as they are no formal targeted disease, as newborn are not symptomatic, but the family should be informed, and it's easy to detect because it's only a detection of F hemoglobin, as it is easy to identify. A summary. The essentials for a neonatal sickle cell disease screening is the burden of sickle cell disease is increasing in Europe. It's also increasing in Germany. We probably have 2,000 or 3,000 patients now. All European patients with sickle cell disease should be enrolled into registries, make a standardized data collection, coordinated follow-up, and all phenotypes of sickle cell disease should be included. Considering the efficiency of neonatal screening in France, a screening of the ethnic risk population for sickle cell disease should be appropriate for most European countries with a low frequency of sickle cell disease. By contrast, a universal screening avoids missing patients and possible discrimination. That is the reason why France might be changed, and the reason why Germany might make a universal screening, because it can afford to make a universal screening. And I think in other regions, clinicians have the responsibility to test newborn at risk on case-to-case basis according to family origin, to not overlook a patient with sickle cell disease. So I switch to the second part of my lecture, which I owe to Roswitha Dickerhoff, which is hemoglobin SC disease. You know, there are seven groups of sickle cell disease. I don't have to report to this audience. And hemoglobin SC is most apparent in West Africa and descendants of West Africa living in US, Caribbean, and France. So let's begin with the patient. This patient from Papua New Guinea, 20 years old, had an acute hearing loss and was giving prednisone without any improvement. But the prednisone made anything else. It increased the neutrophils, and the neutrophils caused a severe pain crisis in this patient in presence of a near normal hemoglobin value. So he got a phlebotomy, which improved the hearing and the pain. And the conclusion is that in hemoglobin SC disease with tinnitus or acute hearing loss, first try phlebotomy. If not successful, then do prednisone. But do prednisone only after partial exchange transfusion, because otherwise you will run into pain crisis. This means that hemoglobin SC is not a mild sickle cell disease. 90% of adult hemoglobin SC patients have a hemoglobin level of over 10 grams per deciliter. They have a high rate of otological and ophthalmological problems. By contrast, they have a low rate of strokes, pulmonary hypertension, leg ulcers, and nephropathy. And the treatment is other than in other sickle cell subgroups. Regular phlebotomies can do best for recurring generalized pain. These are not pain crises, but generalized pain for vertigo. And of course, prior to a flight over 6 hours with a hemoglobin level over 11 grams per deciliter. Phlebotomy cannot prevent proliferative retinopathy. And please remember, hydroxycarbamide is contraindicated in a patient with a high hemoglobin level. And these patients need yearly controls of eyes for their proliferative retinopathy. You know, the viscosity is the main problem of sickle cell disease. And viscosity just rises with hemoglobin content. And of course, the abnormal shape of the cells. All sickle cell patients have abnormally shaped red cells. But there was a study in 1982 measuring the oxygen saturation in forearm, and that shows that with a hemoglobin over 10 grams per deciliter in sickle cell patients, the saturation of oxygen is reduced. So that means these patients are endangered by a crisis encountering oxygen depletion. You see the typical picture of SC disease, and you see in contrast the typical picture of a sickle cell HBSS patient. Hemoglobin SC in pediatric patient have a late functional asplenia only after 5 to 10 years. They do not need penicillin prophylaxis. I recall that they have a very low risk of stroke. That means they do not have a need for transcranial Doppler sonography. They have splenic sequestration mostly as adults. Pain crises are rare. They have a high hemoglobin value. Hydroxycarbamide is rarely indicated, and there's an early education on sudden hearing loss, pain crisis, and plane flights. I thank for your attention and thank for the two doctors for coming.